All right. Thank you, everyone, for joining us today. We're very eager to hear from our invited speaker. Before we get started with the introductions, just a few logistics. First of all, this is the usual time for the IFAM seminar series, but today is a very special collaboration between IFAM and NewCats for something new that you might have seen being rolled out, and that's the Translational Application in Public Health seminar series. And Dr. Rupal Mehta is our special speaker for today. For the seminar, we will have the Q&A function at the bottom open for questions, so please submit your questions there, not in the chat option. We will hopefully have a few minutes towards the end for questions and a discussion. All right, well, so for introduction of Dr. Mehta, there's a lot of things to say and a lot of things to highlight, but I thought I would highlight just a few before I give you sort of the traditional background on our speaker today. So in my mind, Dr. Mehta is the epitome of homegrown talent. She has definitely shown us that if you invest in the people you have here and train them, they outshine you and become individuals that can carry the Northwestern name outside of Northwestern nationally and internationally. She is a cross-disciplinary investigator, as you'll see from the work that she'll present today. She'll show you that cardiologists and nephrologists actually don't disagree as often as social media tend to suggest. There's actually a way to collaborate and work together. And in fact, many people who collaborate with her will say that she's a very eager and hardworking collaborator who gets things done. Medical students interact with her quite a lot as well. She teaches them and then they all beg to work with her, and she's published a number of papers with medical students out there. And last but not least, she's an exceptional clinician. In fact, she is on service this week and nevertheless has been able to come up and speak to us for an hour. And I hope all of those things that I mentioned highlight how special she is, and all of the places that she has trained at recognize how special she is. This includes Case Western, where she has served as a chief resident, and nephrology fellowship, where we've recognized her talent and have invested in her development. And actually, the topic that she'll talk about today, she was already very eager to study when she was a clinical fellow. I still remember at one of the clinical talks that she gave, she invited Dr. Sanjeev Mehta to come to the case conference, and he's continues to be her collaborator. So Rupal, without further ado, we're delighted to hear about heart-kidney synergy.
Thank you so much, Dr. Zakova, for that very, very kind introduction. I very much appreciate it. I'd like to thank IFAM, the Institute of Public Medicine and Health, and as well as NewCats for the opportunity and the invitation to speak today. So today I'll be speaking about heart-kidney synergy, an area of passion of mine, both clinically as well as in the research arena. So here are my disclosures, some stock interests and some consultant fees, then also some funding from the NHLBI, NewCats as well, and the National Kidney Foundation of Illinois. So here are the objectives of the talk today. First, we'll talk about the overview of the heart-kidney connection and why it's important. We'll review some epidemiology of cardiovascular disease in patients with chronic kidney disease. We'll then examine the contribution of chronic kidney disease to cardiovascular disease disorders, specifically heart failure. And then I'll tell you a little bit about my current research focus and what we're doing here at the Center for Translational Metabolism and Health in order to study this. So let's start with, why is this topic important? So both cardiovascular disease and kidney disease are common healthcare problems that have high expenditures and increase the risk of comorbidities and death for our patient population. Here's a little bit of a comprehensive schematic of the interaction between cardiovascular disease and kidney disease. These disease states commonly coexist and they share common risk factors as well. And there's various mediators and mechanisms in vascular disease, in heart disease and heart failure, as well as kidney disease, that contribute to the progression of cardiovascular disease in the center here, but also in kidney disease, and influence the prognosis for our patient population. Specifically, though, there's things that are unique to patients with kidney disease that put them at high risk for cardiovascular disease. And then understanding these unique mechanisms of why our patients with kidney disease have this increased risk of cardiovascular disease is vital to preventing cardiovascular disease and finding diagnostics and therapeutics to target in our patient population. So these are data from a landmark study published by Ellen Go in the New England Journal of Medicine back in 2004 that show that as kidney function declines, as our kidney GFR goes from greater than 60 on the left to less than 15 on the right, and as we accumulate complications of kidney disease, our morbidity goes up. There's data that even in early kidney disease, even when GFR is closer to 60, that there's significant mortality and cardiovascular disease events, and that as GFR declines, that the rates of death, as well as you see on the left, and then the rates of cardiovascular events, as you see on the right, rise dramatically. And these data are after adjustment for numerous covariates and socio-demographic characteristics, presence of cardiovascular disease, prior hospitalizations, diabetes, hypertension, all these risk factors that we have. It's independent of that. So there's something in kidney disease that promotes cardiovascular disease and that increases the risk of cardiovascular disease and death in our patient population. And so what are these risk factors? So there's traditional risk factors that we talk about, things like hypertension, diabetes, smoking, dyslipidemia. And then there's also things that are very specific and are non-traditional, that are specific to kidney disease, things like vascular calcification, inflammation, proteinuria in itself, all can be considered risk factors for cardiovascular disease in our patient population. And so when we talk about non-traditional risk factors, I'd like to spend some time on abnormal parameters of mineral metabolism. So those in the nephrology community know how much time we spend on diagnosing and treating abnormalities in mineral metabolism in our patient population. And when we talk about CKD, MBD, or mineral bone disease, we refer to things like laboratory abnormalities, calcium, phosphate, vitamin D, fibroblast growth factor 23. CKD, MBD also encompasses things like abnormal bone parameters or bone abnormalities, as well as vascular calcification. So here's just a few of the data, and there's numerous studies that have been done that link CKD, MBD to cardiovascular disease as well as mortality. So these are data from Jeff Block and Brian Kestenbaum that look at serum phosphate and risk of cardiovascular disease. And those in the nephrology community also know that our patients with kidney disease, especially late-stage kidney disease, have elevated levels of serum phosphate. So on the left are data from approximately 6,000 individuals on hemodialysis that show that as phosphate levels rise, there's an increased risk of mortality. On the upper right, you see data from 6,700 patients with CKD, and they divided phosphate into tertiles, lowest, middle, and highest. And they show that individuals in the highest tertile of phosphate, after adjustment for numerous covariates, have an increased risk of mortality. This is once again after multivariate adjustment. And they also show on a linear scale that every 1 milligram increase in serum phosphate is associated with about a 1.2 increased risk of mortality. And then on the left in the middle, you see data from approximately 3,400 individuals in the Framingham Offspring study. These are individuals without kidney disease and no cardiovascular disease at baseline. They show once again that as serum phosphate rises, and every increase in serum phosphate level by 1 milligram per deciliter is associated with an increased risk of cardiovascular disease. And you can see actually the hazard ratios or the risk ratios are approximately the same in patients with CKD or non-CKD, showing that serum phosphate may provoke cardiovascular disease, whether it be through vascular calcification or other mechanisms in our patient population. So much of the data that I showed you in the prior slide was prior to the identification and incorporation of a hormone called fibroblast growth factor 23 into our clinical studies. And FGF23 is an osteocyte-derived phosphaturic hormone that acts on the parathyroid gland and in kidney to increase secretion of urinary phosphate, but it also has effects of vitamin D metabolism. And on the right, there's data from Dr. Zakova that show that as FGF23 levels rise as kidney function declines. On the right, you have GFRs greater than 70. On the left, you have GFRs less than 20. And as GFR decreases, you see that FGF23 levels rise dramatically. And actually, even in early kidney disease, when kidney function is fairly preserved, FGF23 levels are elevated. And that FGF23 levels rise actually prior to the elevation in PTH and prior to the elevation in serum phosphate. Why does this matter? Well, we have data that show that FGF23 and observational studies that FGF23 is associated with increased risk of cardiovascular disease in patients with chronic kidney disease. On the left are data from the chronic renal insufficiency cohort study, which is a cohort of patients with chronic kidney disease, approximately 3,800 individuals, that show that FGF23 rises in quartiles, that there's an increased risk of congestive heart failure. On the right, there's data from approximately 3,000 individuals from the CRIC study that shows FGF23 levels rise as quartiles increase. There's an increased risk of left ventricular mass index or left ventricular hypertrophy. Data suggesting that FGF23 is linked to cardiovascular disease. I'm not going to show this, but there's also preclinical data that suggests that FGF23 actually binds to a receptor on the cardiac myocyte to increase left ventricular hypertrophy. So this is not just shown in observational studies, but also in the lab data, and that if you block this receptor, you can actually alleviate LVH. So phosphate and FGF23 are just two potential mechanisms in how abnormal CKD-MBD may increase risk of cardiovascular disease in our patients with CKD, and specifically in patients with chronic kidney disease versus a healthy population. And so there's also data on iron stores. So what else in kidney disease promotes cardiovascular disease? And so there's data that iron deficiency in patients with chronic kidney disease may also contribute to cardiovascular disease events. There's a lot of data in the heart failure population, in the heart failure literature, that iron deficiency, as well as iron excess in its relationship with cardiovascular disease. And there's randomized trials in heart failure populations that if you actually give back iron, you can actually improve some cardiovascular endpoints. So we looked at this, and these are data that were recently published in the chronic renal insufficiency cohort study, again, in approximately 38 individuals. And we looked at the association of different iron stores with cardiovascular outcomes. And we divided individuals into quartiles of TSAT and ferritin. And we defined those individuals with the lowest quartile of TSAT and the lowest quartile of ferritin as having iron deficiency. And individuals in the highest quartile of ferritin and the highest quartile of TSAT as having high iron. Those with intermediate levels of both were iron replete. There's also individuals with low quartile of TSAT and high quartile of ferritin as functional iron deficiency, which is very common in patients with kidney disease. And then there's this newly minted group, which is in the mint green group, which had low TSAT, but kind of intermediate ferritin levels that we defined as mixed iron deficiency. So there's these different levels of iron stores that we can have in patients with kidney disease. We wanted to look at the association of these iron stores with cardiovascular outcomes, as well as kidney outcomes, as well as mortality. And what we show first is, compared to the iron replete group, individuals with iron deficiency in the very top purple were significantly associated, had a significant association with heart failure with a hazard ratio of 1.34, as well as with mortality with a hazard ratio of 1.28. So individuals with iron deficient, who are in the iron deficient group compared to individuals with iron replete, had an increased risk of heart failure, as well as an increased risk of mortality. This is after adjustment for numerous covariates and other risk factors. Individuals with the mixed iron deficiency group also had an increased risk of mortality, and individuals with high iron also had an increased risk of mortality as well as heart failure. So really, abnormal iron stores in our patients, whether it be iron deficiency, mixed iron deficiency, or high iron, is actually associated with poor outcomes in our patient population. Interestingly, we know that iron deficiency in our patients with kidney disease actually upregulates FGF23, which is actually, which we discussed before, is associated with heart failure and mortality. There's an abundance of preclinical data that actually demonstrate this. So knowing that, we went on to see if FGF23 mediates or is responsible for any of these associations between our abnormal iron stores and our outcomes, hypothesizing that FGF23 would at least mediate some of the effects of iron deficiency and maybe even mixed iron deficiency on mortality and heart failure. And when we put FGF23 into these models and we do formal mediation analyses, our hypothesis was actually correct. Well, first we show that individuals with iron deficiency and any of our abnormal iron stores of mixed iron deficiency and functional iron deficiency have high FGF23 levels compared to those with iron replete and high iron. And we show that PTH is actually the same in all of these groups. So there's something about iron deficiency or any of our iron deficiency groups that does show that we can upregulate FGF23 in these disease states. But then we go on to show that FGF23 does, in fact, mediate a lot of our associations between iron deficiency and heart failure as well as mortality. When you put FGF23 into these models, the association completely goes away. When you put FGF23 into the model with mixed iron deficiency, it partially mediates the association of mixed iron deficiency with mortality, about 20% in formal mediation analyses, and it doesn't mediate any of the association with high iron. So what does this all mean? Really, it's showing that there's abnormalities in patients with kidney disease, whether it be abnormal iron stores, whether it be abnormal mineral metabolism parameters that increase our risk of having cardiovascular disease. And all of these data are really trying to show, why our patients with kidney disease have this increased risk, and is there something we can do about it? Whether it be FGF23, can we lower FGF23? Whether it be abnormal iron stores, and can we fix these iron stores? All of these things are potential mechanisms of increased cardiovascular risk in our patient population. We'll go on to show that, when we talk about cardiovascular disease, there's certain different types of cardiovascular disease. And these are data from the CRIC study, again, by Nisha Bansal, that look at heart failure specifically. And in here you see that as eGFR declines, and we go from GFR of greater than 45 to less than 30, or we go from UACR being very low to less than 30 to greater 300, or you combine these parameters, that the burden of heart failure in our patient population increases. And any of us know, when we take care of our patients with kidney disease, that the risk of heart failure and heart failure hospitalizations is quite high. And so a lot of our research focuses on why are patients with kidney disease at an increased risk of heart failure. The opposite is also true, that patients with heart failure have kidney disease as well. And having kidney disease, if you have heart failure, also increases your risk of mortality. So these are patients, cardiology always has larger studies than we do, and approximately 120,000 individuals on the left that show that patients with heart failure have kidney disease, and kidney disease is quite common in our patients with heart failure. And on the right, that show that as eGFR declines, that in patients with heart failure, if you have a lower eGFR, you have an increased risk of death and mortality. Just some data that show that heart failure is common in patients with kidney disease, and kidney disease is common in patients with heart failure. So how do we evaluate heart failure risk in patients with kidney disease? Despite knowing that heart failure burden is really high in kidney disease, risk prediction models that look at heart failure risk, basically in kidney disease are non-existent. There's a PCP heart failure equation, is a 10-year heart risk equation for incident heart failure that's been validated and endorsed by the ACC, the AHA, the HFSA, and this risk score integrates a lot of clinical parameters that are readily available in primary care settings. It includes things like blood pressure, glucose, BMI, cholesterol, smoking, some ECG findings, and really it's this idea that can we predict which one of our patients are going to have heart failure? Well, we looked to see if we could validate this risk score in our kidney disease population, because it's been validated in a lot of general populations where providers can use this risk score to say, are my patients at increased risk of heart failure? So we said, are our patients with CKD at risk for heart failure using this equation? And can we predict which one of our patients with CKD are at risk? And so we looked to validate this, and we saw when we use this equation in our kidney disease patient population, this risk score actually underestimates events in kidney disease, and that there's inadequate discrimination, poor calibration with this equation in our patient population. You can see the C statistics are quite low, and the G&D chi-square that looks at calibration is actually less than 0.05, also showing poor calibration. And actually, you can see the calibration plots on the left. We underestimate risk of heart failure in our patient population using something like this equation. And so this is actually what we hypothesized. So when we add markers of kidney function into this equation, so when we add markers of kidney function like proteinuria or GFR to our equation, we said, would that improve model performance? And we can now see the calibration plots on the left when you add UACR. And we show that when you add UACR to this model, our C statistics improve, and we have excellent to acceptable discrimination. Our G&D chi-squared improves. So really showing that when you add parameters of kidney function to a heart failure risk model, we can actually improve prediction. So all of these data together together, what does this mean? It suggests that CKD is a risk-enhancing factor for heart failure, and that we could prevent heart failure if we could figure out what patients in our kidney disease population, are at highest risk. And it seems to be that patients with higher proteinuria or lower GFR are at risk. So now that we've gone through some of the epidemiology, let's dive a little bit further into mechanisms. What contributes to worsening kidney function in heart failure or heart failure in patients with kidney disease? So we previously thought there was the forward flow hypothesis, that if that decreased heart function, decreased cardiac output would result in arterial underfilling, decreased renal blood flow, activation of sympathetic nervous system and RAS, which would then lead to worsening kidney function. In the heart failure literature and the cardiology literature, they call worsening renal function is defined as a creatinine rise of 0.3 or a 15% reduction in GFR. And so the thought was that all of this led to worsening kidney function, then worsening kidney function, as I've shown you with risk equations and epidemiologic studies, that worsening kidney function then leads to worsening heart function and heart failure hospitalizations, worsening heart failure function then leads to worsening kidney function, and we go into the circular kind of effect. But there's also data that maybe this isn't the only hypothesis, that there's this venous hypertension hypothesis, that congestion or having venous congestion or being volume overloaded is actually results in worsening kidney function in our patient population. It's not just forward flow, but it's kind of backflow and congestion that leads to a decreased perfusion gradient in our kidneys, which then leads to activation of the sympathetic nervous system and RAS and worsening kidney function, and then leads to worsening heart failure function and circular. And so, worsening renal function is associated with both increased and decreased mortality. And so what does this mean? So we know that kidney function gets worse sometimes in patients with heart failure, and that when we try to decongest them, when we try to get fluid off of our patients with heart failure, that creatinine may go up. The creatinine going up is associated with both increased and decreased badness. And so this was a study of about 430 individuals in the SCAPE trial, and they looked at decongestion, meaning can we get fluid off? And they looked at decongestion in 4 ways. They looked at it by hemodynamics, clinically, they looked at by hemoconcentration and plasma volume. And they show that if you have worsening renal function, if creatinine rises with decongestion, that if you can decongest patients, you could actually, even if your creatinine rises, it's associated with improved outcomes. However, if you have a rise in creatinine or worsening renal function and you still remain volume overloaded, you still have congestion, that's associated with worse outcomes. So really, it's not about the creatinine rising, it's about whether we can get our patients eubulemic or without a lot of fluid on board and without fluid in their lungs, and we can get them decongested. Basically, having persistent congestion in our patients was bad. And so this highlights the difference between worsening renal function and true kidney damage and injury. GFR represents functional change in our kidney function. And if we have a loss of function, but without true kidney damage, that's where a lot of our heart failure patients are, where we have loss of function, creatinine goes up, GFR comes down, but there's not true kidney injury. And this was probably, like I said, where a lot of our heart failure patients sit at, and that we shouldn't always just stop diuresis or decongesting because kidney function worsens. There's lots of studies to see, can we differentiate loss of function versus true damage, looking at tubular markers and other biomarkers. And I don't think we've figured out exactly what the best markers of tubular damage are yet, but we know that creatinine sometimes is not always the best marker, and that although there's a loss of function, there's not really true damage. So really, decongestion is the holy grail, not just for heart failure patients, but also for kidney patients. And there's an interesting study, although small, of about 200 individuals that showed that renal dysfunction was cited as one of the most common reasons for discharge from the hospital with residual congestion. And I've already shown that residual congestion or having persistent congestion in our patients is bad. And I'm not sure it's always us as nephrologists, I think we recognize that creatinine can go up, but it is scary when kidney function worsens and creatinine goes up, and us pushing decongestive therapy. But we know that renal dysfunction is cited as one of the most common reasons that we stop decongestive therapy. But we know that if we stop decongestive therapy and patients have persistent congestion, then that's bad. And so the goal is continued decongestion, regardless of if creatinine sometimes goes up. This is from Twitter, actually, from Greg Fonero, that talk about the 4 pillars of medical therapy for heart failure. And there's probably a 5th pillar too, which is diuretics. But they, you know, these are the GDMT, and how do we improve our patients? You know, how do we provide heart success in our patients with heart failure? And there's medical therapies like ARNIs and beta blockers and MRAs and SGLT2 inhibitors. And these are some of the more newer treatments in GDMT for heart failure. But I would argue that we have pillars for GDMT for patients with kidney disease and heart failure as well. We have great data on ACEs and ARBs, and we have now wonderful data on SGLT2 inhibitors and nonsteroidal MRAs as well that show that addition of these agents in patients with kidney disease on top of ACEs and ARBs can actually benefit our patients, not only from a heart standpoint, but also from a kidney disease progression standpoint. And so we should start seeing the use of these agents to provide benefits for kidney disease as well as heart disease in our patient population. And so what does dual SGLT2 inhibitor and RAS blockade do in kidney disease? Well, SGLT2 inhibitors causes afferent vasoconstriction. RAS blockade causes efferent dilatation. And so putting these two together with SGLT2 inhibition and RAS blockade may be able to decrease intraglomerular pressure, decrease hyperfiltration, and provide kidney protection in the long run. And this is why we see rises in creatinine with both ACE inhibitor initiation as well as SGLT2 inhibitor. But once again, another area where we see rises in creatinine and decreases in GFR in the short run, but in the long run can actually help benefit our patient population. So how do SGLT2 inhibitors work in our patient population, and how do they improve renal and cardiovascular disease protection? And do we understand the mechanism? And I don't think we do. There was at a recent national conference that said when there's so many different mechanisms of how one drug can work, it really means we don't understand the mechanisms. And some people think it's because of natriuresis. Some people think it's because of decreasing intraglomerular pressure. Is it because of better glycemic control, weight loss, improved hypertension? There's lots of different possible mechanisms, and I don't think we truly understand how SGLT2 inhibitors work in our patient population, but we do know that they improve renal and cardiovascular outcomes. So what are we doing now, and how are we moving forward? Well, we're now building things like cardiorenal metabolic clinics, and it's something here at Northwestern we're trying to do. And we're looking at multidisciplinary care models that both inpatient as well as outpatient to improve outcomes for all of our patients. And so we'd say protect your kidneys and save your heart, and kind of do both. And I think we can. And like I said, you'll see lots of institutions, not just Northwestern, moving towards these multidisciplinary care models to make sure that our patients are on medications and therapies that improve both heart function as well as kidney function. So let's move a little bit forward into both my clinical interest as well as my research interest. And so, I'm trying to kind of combine both kidney disease, heart failure, and then another area of study, which is metabolomics, to look to see if we can understand the mechanisms of cardiovascular disease in our patient population, and if we could provide or find an area of therapeutic intervention that could improve patients' both cardiovascular disease progression as well as kidney disease progression. And so there's something called heart failure with preserved ejection fraction in kidney disease. So heart failure has kind of two buckets, those with reduced ejection fraction and those with preserved ejection fraction. There's also recovered or recovered ejection fraction as well as mid-range ejection fraction. But my work focuses on heart failure with preserved ejection fraction. And we know that individuals with kidney disease have an increased risk of HFpEF, actually, more so sometimes than HFrEF or reduced ejection fraction. And why are patients with kidney disease get HFpEF? Well, there's lots of proposed mechanisms, whether it's shared comorbidities such as diabetes, obesity, or hypertension, vascular changes such as hypertension and arterial stiffening, neurohormonal changes such as RAS activation or sympathetic hyperactivity, whether it's systemic inflammation or things like mineral metabolism parameters. All of these are abnormal in our patients with kidney disease and may lead to things like microvascular disease, may lead to things like HFpEF. when people have studied HFpEF, so Sanjeev Shah here at Northwestern is an internationally recognized investigator of HFpEF, and they've done phenome analyses, and HFpEF is sometimes thought of as a mixed bag. And so they used and conducted a variety of algorithms and conducted deep phenotyping of patients with HFpEF, and they found that there's unique patterns of associations among certain variables. And they looked at clinical variables, laboratory variables, imaging variables, and they phenome-mapped these variables in their patient population. They found that it was a very heterogeneous syndrome. And they used a model-based clustering approach that looked at to see if they can define different clusters of HFpEF. And they found 3 different clusters, or 3 different phenogroups. And in these phenogroups, 1, 2, and 3, phenogroup 1 was a younger population and had lower BNP than participants in the other group. Phenogroup 2 had the highest prevalence of obesity and diabetes and obstructive sleep apnea. And then there's this phenogroup 3, which was the oldest, but they were also the individuals who had the most likely to have chronic kidney disease, with the highest serum creatinine and lowest EGFR. They also had the highest BNP and other variables. And that they saw that this phenogroup 3, this group that had chronic kidney disease, that this group actually had the worst outcomes, whether they looked at cardiovascular hospitalizations as well as death. They saw that phenogroup 3, this group that had kidney disease, had the worst outcomes. So once again, suggesting that kidney disease represents, kind of badness in patients with heart failure in general, and that these patients are at increased risk of mortality. And so the goal here is to study our patients with kidney disease who have HFpEF. I'm going to switch gears slightly and say, talk about the study of metabolomics, and I'll bring it all together. So what is the study of metabolomics? Well, the study of metabolomics, are biologic precursors. Metabolites are biologic precursors in our body, and they represent the end product of our genes. And so, biologic processes include DNA, or the interactions between our genes and DNA and RNA and proteins and metabolites. And these interactions then lead to some sort of phenotypical disease. And so the study of metabolomics is the study of these metabolites in this biologic system. It's a net basically product of our genes, and it could reflect a disease state at any given point. But the thing is, the metabolome is highly dynamic. It can change second to second, minute to minute, depending on diet, depending on drugs, depending on various different things. And it could be different in different organ systems. It can be different in different tissues. And so you could look at metabolites or specific metabolites in organs, in different tissues, or you can look at systemic metabolites, which is the basically culmination of what's going on in all of our different organ systems. So why does this matter? Well, numerous studies have looked at metabolic profiling in heart failure, for example, and that's shown that there's certain metabolites, specifically here looking at acylcarnitines, that are elevated in patients with heart failure compared to individuals without heart failure, and that these metabolites are significantly higher in HFpEF and HFrEF, and then they're also associated with declining ejection fraction as well. And so what are acylcarnitines? Well, acylcarnitines, in terms of metabolites, are intermediates in the fatty acid beta oxygenation pathway. And structurally, they're long-chain fatty acids that are esterified to carnitine. And functionally, they facilitate transfer of these long-chain fatty acids into the mitochondria for energy utilization. And prior studies have shown that increased levels of acylcarnitines in heart failure, are associated with worse functional status, with mortality, in patients with stable heart failure. And there's lots of different proposed mechanisms because they may have direct adverse adverse effects, both cellularly as well as physiologically. And they can maybe promote inflammation and systemic inflammation, and so there's lots of proposed mechanisms. What we see is that these long-chain acylcarnitines are increased in patients with heart failure and associated with kind of badness. Well, what about metabolomics in kidney disease? So these are data from Eugene Rhee, a collaborator at MGH, and he's looked at certain metabolites in kidney disease progression. And he's shown that there's certain metabolites that are associated with worse kidney function and that are associated with kidney disease progression over time. What does all of this matter? Basically, I'm trying to show you that, metabolites change with kidney function, that kidney disease affects the circulating metabolome. And so now I've shown you that metabolites change in heart failure and associate with badness in heart failure, and that metabolites are affected by kidney function. And so what is our emerging hypothesis, and how do we put all of this together? So the current purpose of my research focus is, and with the support of NUCATS as well as the NIH, is to see if alterations in the metabolome because of reduced kidney function, whether it be because of gut absorption in patients with kidney disease, whether it be because of medications and catabolism, whether it be because of true kidney function decline or filtration, whether that leads to alterations in the circulating metabolome, which we think it does, specifically acylcarnitines and certain precursors of energy utilization, and if that is associated with subclinical heart failure or preclinical heart failure. So we showed that certain metabolites are different in heart failure versus controls, but can we prevent, or can we look at patients without clinical heart failure, but maybe some early alterations in their heart function, and that can these metabolites be associated with subclinical heart failure and reduce functional capacity and exercise in our patient population. So I'll show you some very preliminary data. So first, I'm going to show you that patients with kidney disease have alterations in their cardiac mechanics. And what do I mean for that? So here we're looking at patients without heart failure. These are patients part of the cardiovascular health study. And we're looking at individuals without heart failure, with and without kidney disease. And when we talk about kidney disease, we say, GFR is less than 60. And we see that there's certain parameters when we look at echocardiograms or 2D STE, that these parameters are all worse in patients with kidney disease. These are patients, like I said, without heart failure, but they have abnormalities on these on their echocardiograms. Their abnormalities are an LVLS or LV longitudinal strain, LARS or left atrial reservoir strain, right ventricular free wall strain, other markers of diastolic dysfunction. And what do these markers mean? Well, these are all markers of subclinical cardiac dysfunction. These parameters on speckle tracking echocardiography can actually look at early changes in how our heart functions. So clinically, these patients don't have heart failure. When you look at traditional echocardiograms, they have normal heart function. But when you look at this speckle tracking echocardiogram and you see how their heart function is working, we see these alterations, very subtle alterations in their cardiac mechanics. And they all suggest impairment of heart function despite not having clinical disease. Interestingly, individuals with kidney disease, many of them had global longitudinal strain that was less than 18%. And that the number doesn't mean a lot to many people in the audience, but what it does suggest is that these patients have subclinical HFpEF, that these patients with kidney disease are a prime substrate for having HFpEF and may have future clinical HFpEF as well. We go on to show that these patients, that these parameters in 2DST are actually associated with kidney function decline over time as well. So when we put this all together, what do we see? So we see our patients with kidney disease have alterations in cardiac mechanics and may have subclinical HFpEF. When we look at metabolites in our patients with kidney disease, and we've done this in the Mehta study, we've looked at individuals with and without CKD. We show that these acylcarnitines that I showed you before that were associated with poor outcomes in heart failure are elevated in patients with CKD versus not having CKD. So once again, showing that acylcarnitines are elevated in patients with CKD, and we hypothesize that are these acylcarnitines or these levels of metabolites associated with cardiac disease in our patient population. So we're looking at this in the CRIC study. So once again, the CRIC study is a population of individuals with kidney disease. And we're looking at metabolites in these patients, specifically acylcarnitines. And we want to see, are these acylcarnitines associated with cardiovascular events? Are they associated with LV mass? Are they associated with cardiovascular disease like heart failure events? And are they associated with things like mortality? And we have some preclinical data that I'm not going to preliminary data that I'm not going to show you here, that acylcarnitines were elevated in our patients with kidney disease, and that acylcarnitines are associated with lower GFR. So as GFR declines, these acylcarnitine levels go up, and that as acylcarnitine levels go up, they're actually associated with LV mass as well. So higher acylcarnitines are associated with higher LV mass, and these are data that we're actively looking at right now. Can we alter these metabolites? So that's the other question. So let's say we show that these acylcarnitines are associated with kidney function and that they're associated with badness in our patients with kidney disease. They're associated with LV mass. They're associated with heart failure outcomes in our patients with kidney disease. Well, can we alter them? So this was a small study that was published, only 19 individuals. They looked at an SGLT2 inhibitor, and they said, if we give our patients an SGLT2 inhibitor, which we already know improves heart function, improves kidney function over time, can we alter these metabolites? And we actually see that administration of dapagliflozin for 12 weeks can change our metabolite levels, and that can actually change specifically acylcarnitine levels or long-chain acylcarnitine levels, as well as other pathways of energy utilization. And so we kind of ran with this data, and we're performing a study right now where we're taking patients with kidney disease and we're looking at their cardiac mechanics. We're giving them an SGLT2 inhibitor, and then we're going to follow them over 6 months. And then we're going to check their cardiac mechanics again, and we're going to look at their functional status. But more interestingly, we're also going to be looking at their metabolites before and after empagliflozin or SGLT2 inhibitor therapy, really hypothesizing that can we give really hypothesizing that if we give these patients an SGLT2 inhibitor, can we change their metabolites, specifically acylcarnitines? Can we lower them? And will that show improvement in these changes in cardiac mechanics that I showed you, all those strain parameters and all the parameters of subclinical heart failure? So before our patients actually have heart failure, can we alter their cardiac mechanics by SGLT2 inhibitors? That would be beneficial. Can we alter these subclinical changes in cardiac mechanics? And so this is one of our study coordinators right now, or he was a study coordinator, and he's performing what we call a cardiopulmonary exercise test. And he's on this supine bike, and he's, exercising, and we're measuring, we're actually measuring his oxygenation, his pulmonary status, his functional status, and we're actually measuring their 2-DSE. And this is done at Sanjeev Shah's lab in the cardiac physiology unit. And so these patients, our CKD patients, are actually actively doing this right now, and we're recruiting patients. And we're going to measure their metabolites. We're going to put them on one of these tests, and then we're going to measure their metabolites after 6 months of therapy as well. And we're going to remeasure their functional status and their 2-DST and see if we see improvements. So like Dr. Izakova said at the very beginning, this is a multidisciplinary effort. We are working with the cardiac physiology lab with Sanjeev Shah. We're performing, very, sophisticated analyses on metabolites and the metabolomics to look at systemic metabolites and if these change over time with SGLT2 inhibitors. And so there's a lot of statistical support. There's a lot of support from the metabolomics. We have a lot of study coordinators who are helping recruit patients from our CKD clinic actively into these studies. The Division of Nephrology is actually helping out a lot in terms of finding patients for us and talking to patients about our studies as well. And so this is a multidisciplinary approach to seeing if we could find mechanisms of cardiovascular disease in our patient population. I'm going to end a little bit early here. I want to say a special thanks to the Division of Nephrology, CTMH, as well as IFAM, NUCATS, and the KL2 program, who had funded some of this early work and helped get NIH funding, or helped me get NIH funding to continue this work, as well as the Cardiac Physiology Lab and the Division of Cardiology as well, who are really working with us to help understand cardiac mechanics in our patient population. It's a picture of my daughter who just turned 5 months a few days ago. So I'd like to thank the listeners as well as everyone else for this opportunity.
Great, that's great. Thank you very much, Rupal. That was really fantastic. While people are thinking of questions, which you should please put into the Q&A on the bottom, I'll just ask a few and maybe ask you to just look back and reflect on sort of the complexity of the problem that you're studying and the necessity to collaborate across disciplines. Can you maybe reflect on some challenges and some facilitators for being a cross-disciplinary investigator?
Yeah, I think, the biggest thing is we can't work in silos, right? I mean, the truth is these disease complexes or the disease processes are complex, and we may have expertise in one area. For example, I'm a nephrologist and we may have expertise in kidney disease, but, I don't know how to, for example, read a 2D speckle tracking echocardiogram, right? And I don't know, there's certain things that we don't know, or I don't know in terms of how to interpret cardiopulmonary exercise testing and perform these studies. And so I think it's important that we don't work in silos and that we reach across aisles and we work in multidisciplinary teams, because I think we can do a lot more that way than working individually. And I think, working with Dr. Shah's lab has really taught us a ton about our patients and, do they tolerate these tests? What patients should we put on, what patients, are contraindicated for getting these types of tests. What do these tests mean? What do these tests mean in our patient population? Can we interpret them? And so there's challenges, of course, because you've got to find time to work together. You have to find good collaborators who are willing to teach you and spend time with you to understand these things. And I've been fortunate to have that. But so you've got to find you have to find great collaborators who are willing to, especially early on in your career, who are willing to kind of take you under their wing and explain certain things. I am not an expert in metabolomics and statistical analyses of large data sets and deep phenotyping. And I'm not an expert in cardiopulmonary exercise testing as well, but I do know kidney function and I do know kidney disease. And so, finding collaborators, in metabolomics as well as cardiology has really helped move these projects forward. And we wouldn't be able to do this without them.
All right, great. So there are some specific questions on the information you presented. First, is acylcarnitine cleared by the kidney?
Yeah, it's a great question. And I think some of them are, there's no question that as kidney function declines, that the levels of acylcarnitines go up. And we have data that show that. And so I think there is some clearance through the kidney, and that may be one reason why these levels go up in kidney disease.
And then there's a clinical question. Are SGLT2 inhibitors contraindicated in dialysis patients?
So it's a good question. So, we don't initiate SGLT2 inhibitors in our dialysis patients, but all of the studies have shown, and now, current studies, that we can initiate SGLT2 inhibitors with GFRs as low as 20. And that data, the EMPA kidney study was just stopped or terminated early for benefit, and they recruited patients down to a GFR of 20. But most of these studies have also shown that if these patients progress and their kidney function declines and they reach needing dialysis, that we don't need to stop these therapies, but we don't initiate them on dialysis, but it doesn't need to be stopped.
Okay, and then another scientific question. If the participants in your interventional design, all of a sudden prior to that, the clinical doctors actually start prescribing a lot of GLP-1s and other drugs like SGLT2 inhibitors, will that affect your metabolomics data?
Absolutely. There's no question that medications, diet, all affect systemic metabolites. And so we're pretty strict in terms of our inclusion criteria. So for example, we are not including patients with diabetes. And I know that's a large patient population of patients with kidney disease, but because glycemia and the medications to treat diabetes does affect their systemic metabolites, we really want to look at the contribution, not of diabetes and CKD to metabolites, but truly look at the contribution of kidney disease to systemic metabolites. So we're not including patients, for example, who have diabetes, and we're not including patients who are already on SGLT2 inhibitors. And that may be harder and harder to recruit patients as we start or initiate these therapies in our patient population. But the truth is, implementation of new novel therapies and new drugs in our patient population is sometimes slow. So we're still able to recruit patients into this study, because many of our patients have not been started on SGLT2 inhibitors just yet.
And there are two people here very interested about the link between acylcarnitines and SGLT2 inhibitors. There's one question about whether or not you know a mechanism. And then there's a suggested mechanism. Is it possible that SGLT2 inhibitors induce a decrease in endogenous fatty acid metabolism in the proximal tubule by decreasing sodium reabsorption and thereby decrease fatty acid carnitine levels?
Yeah, I don't think we know. These are the studies were actually quite small, that were done in this. And there's not been a ton of studies looking at metabolites and SGLT2 inhibitors, but there's the author of that paper is probably one of the few authors who has done this work. There is also some data on ACE inhibitors affecting acylcarnitine levels and also being able to lower acylcarnitine levels. And I thought that was interesting because some of the mechanisms of how ACEs and SGLT2 inhibitors work in the kidney by decreasing hyperfiltration is the same. And so I don't think we know the mechanism of action of how these may change metabolite levels, but it's just one hypothesis. And the person maybe who had hypothesis by changing levels in the proximal tubule, it could be something like that. I don't think we know though.
There's a question about how do you define heart failure when there is preserved ejection fraction? And I have a follow-up question related to that, but maybe answer this first.
Yeah, how is HFpEF defined in our patients? And so, in some of the cardiologists, if there's cardiologists in this audience, they'll probably know better than I do, but there's a lot of parameters of diastolic dysfunction. I think the gold standard might be cardiopulmonary exercise testing as well, which is what we're doing to define, heart failure with preserved ejection fraction. But these patients have, may have clinical heart failure, but they have EFs that are not reduced. Subclinical heart failure, so we're looking at patients who don't actually have a clinical diagnosis of heart failure. And how do you define that? And that is what we're actually defining in these studies. We're defining what is subclinical heart failure by looking at these parameters on 2D-STE that are early alterations in cardiac mechanics and saying, do these patients with abnormalities or in their deformation patterns of their myocardium by changes in LV longitudinal strain or RV free wall strain or LA strain or reservoir strain or increased filling pressures, can we use those parameters to define subclinical heart failure in our patient population?
Yeah, and I was going to comment that you alluded to that cardiologists have large clinical trials. There was a recent editorial by Ravi Patel and Sanjeev Shah here that actually the next stage of heart failure preserved ejection clinical trials shouldn't be large clinical trials. It should be small precision clinical trials where you do some of this phenotyping up front and enroll a very specific subgroup of the population in whom you think your intervention is going to work.
Yeah, and maybe those patients should be kidney patients, actually. I think nephrologists are actually pretty good at performing mechanistic studies. The early studies of ACE inhibitors and how they worked in tubular dynamics and things of that sort were performed by nephrologists. And so I agree, I think nephrologists are pretty good at performing mechanistic studies and maybe not as great as at enrolling patients to these, hundreds of thousands of, patient population clinical trials, but, very good at performing small physiologic studies. And these physiologic studies in HFpEF and CKD would be quite interesting.
Okay, it seems like there are two questions that are related. One question is, how much of a rise in serum creatinine is acceptable when you're trying to decongest a patient? And the related question is, if the creatinine rises, how does it not reflect kidney damage? So maybe you can elaborate on that.
Yeah, so when creatinine rises, how does it not reflect kidney damage? Well, we know that there's hemodynamic changes, when we give things like ACE inhibitors or SGLT2 inhibitors or and things of that sort. So when we decongest patients, and we give them diuretics and the creatinine rises, it may just be, hemodynamic effects, but it also may just be, dilutional effects, things of that sort that can cause the creatinine to rise. But when you look at true tubular markers of damage, and they've done this, things with like NGAL and KIM1 and other true markers of tubular damage, we've seen in small studies that those markers are unchanged in these patients despite creatinine rising. So that's why we say there's a change in filtration or function maybe, but not a true damage in these kidneys in these patients. how comfortable are we in terms of what serum creatinine are we comfortable with in a rise? I think that's provider dependent. I know we with things like, medications like SGLT2 inhibitors and ACE inhibitors, we expect a 30% rise or up to a 30% rise in creatinine. With diuretics, the real question is not how much is your creatinine rising, but is the patient still volume overloaded, and what are their true hemodynamics? And so when we diurese patients and we see this rise in creatinine, the most helpful thing is to work with the cardiologists and heart failure doctors and say, can we get actual parameters of their hemodynamics? Can we get right heart catheterizations and Swan numbers and say, what are their true intracardiac filling pressures? And if their true filling pressures are still elevated, that means they still need decongestion, whether or not their creatinine is rising or not, because we know that if they remain with elevated filling pressures and remain congested, that's actually bad for the patient, both symptomatically, but also bad for the patient in terms of long-term outcomes.
Great. So now there's, I think maybe the last question. So the impact of kidney transplantation on improvement in heart function is controversial. Do you think that with this more comprehensive approach to measure heart function, we would see some new findings when we looked at pre-post transplantation?
Yeah, it's a great question. By the time our patients have end-stage renal disease or getting kidney transplants, many of them have fairly advanced CKD. We're studying an earlier CKD population. Like I said, we're looking for subclinical disease, but a lot of our patients, by the time they get to kidney transplant, because of lots of reasons, things that we talked about, CKD MBD, FGF23 levels, which are astronomically high by the time you get to ESRD, vascular calcification, which is very predominant by the time you get to ESRD, that, those things may not be reversible. And so these patients, a lot of our patients, by the time they get transplanted, have HFrEF or reduced ejection fraction, have LVH, and I'm not sure we're able to reverse that with just true reversal of their kidney function or giving them, a kidney transplant. And I think that's why we have to look earlier in kidney disease, and we have to talk about these subclinical markers, and can we prevent heart failure hospitalizations? Can we prevent these subclinical changes in cardiac mechanics from progressing to true clinical heart failure?
So I'll just add that Alex Kula, who's a pediatric nephrologist, is very interested in this question as well, and I think is right now designing a proposal where he may look at pre-post transplantation in children. And children also get diastolic dysfunction, interestingly, fewer confounders, etc., but still the effect of kidney function is there. So thank you very much, Rupal. This was terrific. Lots of interest, and I think lots of people will be asking you questions even after this seminar. So thanks again, and we'll give you a chance to go back to take care of patients today.
Okay, thanks so much, everyone.
Bye-bye.
Thank you.